Question 1. The assessment process reveals a radiation oncologist treating a patient with a newly diagnosed malignancy. The oncologist is aware of a cutting-edge, albeit significantly more expensive, treatment modality that has shown promising early results in clinical trials, and which their institution is actively promoting. Standard, well-established treatment options are also available and have a proven track record of efficacy for this condition. At considerably lower cost, the oncologist has a professional relationship with the manufacturer of the new technology. The patient is seeking the most effective treatment and has expressed a willingness to explore all options. Which of the following approaches best upholds the ethical and professional obligations of the radiation oncologist in this scenario? Option A. Suggesting the patient research the newer technology independently and then make their own decision, without providing detailed comparative information or disclosing the professional relationship with the manufacturer. Option B. Presenting all available treatment options, including the standard modalities and the new technology, detailing the evidence for each, their respective risks and benefits, and the associated costs, while clearly disclosing their professional relationship with the technology manufacturer, and then facilitating the patient's autonomous decision. Option C. Recommending the new, cutting-edge treatment modality as the primary option due to its promising early results, emphasizing its potential superiority, and downplaying the established treatments to ensure the patient receives the most advanced care. Option D. Focusing solely on the standard, well-established treatment options, as they are proven and cost-effective, and not mentioning the newer technology to avoid confusing the patient with unproven or overly expensive alternatives. Correct answer is B. Presenting all available treatment options, including the standard modalities and the new technology, detailing the evidence for each, their respective risks and benefits, and the associated costs, while clearly disclosing their professional relationship with the technology manufacturer, and then facilitating the patient's autonomous decision. Explanation. This scenario presents a common ethical dilemma in radiation oncology, where the physician's professional judgment, patient autonomy, and the potential for financial gain intersect. The challenge lies in balancing the best interests of the patient with the physician's ethical obligations and adherence to professional guidelines. The National Board of Examinations in Radiation Oncology, India, emphasizes a patient-centric approach, grounded in principles of beneficence, non-maleficence, autonomy, and justice, as outlined in relevant Indian medical ethics codes and professional conduct guidelines. The correct approach prioritizes the patient's well-being and informed decision-making above all else. This involves a thorough discussion of all viable treatment options, including their risks, benefits, and alternatives, without any undue influence from potential financial incentives. The physician must ensure the patient fully understands their condition and the implications of each treatment choice, empowering them to make an autonomous decision. This aligns with the ethical principle of patient autonomy and the physician's duty of care, as mandated by professional bodies in India. An incorrect approach would involve subtly or overtly steering the patient towards a particular treatment based on factors other than their clinical best interest, such as the availability of a newer, more expensive technology that the institution or physician has a financial stake in. This constitutes a conflict of interest and violates the principle of beneficence, as it prioritizes potential financial gain over the patient's optimal care. Such actions can erode patient trust and are contrary to the ethical standards expected of radiation oncologists in India, which emphasize transparency and patient welfare. Another incorrect approach would be to withhold information about less expensive or established treatment modalities, thereby limiting the patient's ability to make a truly informed choice. This infringes upon the patient's right to autonomy and violates the physician's duty to provide comprehensive and unbiased information. The professional reasoning framework for such situations involves a systematic evaluation of the patient's clinical condition, a comprehensive review of evidence-based treatment options, open and honest communication with the patient and their family, and a commitment to acting solely in the patient's best interest, free from external pressures or personal financial considerations. Question 2. Analysis of potential dissymmetry errors in a complex radiotherapy treatment plan, considering patient-specific anatomical variations and the potential impact on both tumor control and normal tissue complication probability, requires a systematic approach to risk assessment. Which of the following best represents a comprehensive risk assessment strategy for ensuring the accuracy and safety of radiation dose delivery in accordance with established principles of radiation oncology practice in India. Option A. Prioritizing the speed of dose verification procedures to minimize treatment delays, accepting minor deviations if they fall within broadly defined acceptable ranges. Option B. Focusing quality assurance efforts exclusively on the most frequently reported types of dosimetry errors, assuming other deviations are negligible. Option C. Relying primarily on historical data of common dosimetry errors encountered in similar patient populations to guide quality assurance checks. Option D. Proactively identifying potential dosimetry deviations, evaluating their likelihood and clinical significance, and implementing targeted mitigation strategies based on a thorough understanding of the treatment plan and patient anatomy. The correct answer is D. Proactively identifying potential dosimetry deviations, evaluating their likelihood and clinical significance, and implementing targeted mitigation strategies based on a thorough understanding of the treatment plan and patient anatomy. Explanation: this scenario presents a professional challenge due to the inherent variability in patient anatomy and treatment delivery, necessitating a robust risk assessment framework to ensure patient safety and treatment efficacy within the established regulatory guidelines for radiation oncology in India. The National Board of Examinations mandates a thorough understanding of dosimetry principles not just theoretically, but in their practical application to mitigate potential harm. The correct approach involves a systematic evaluation of potential deviations from the planned dose distribution and their clinical consequences. This aligns with the principles of quality assurance and patient safety, which are implicitly and explicitly emphasized in the training and practice of radiation oncology in India. By proactively identifying and quantifying risks associated with dosimetry, practitioners can implement appropriate corrective actions, thereby upholding the highest standards of patient care and adhering to the spirit of regulatory oversight aimed at minimizing errors. This proactive risk management is a cornerstone of responsible medical practice. An incorrect approach that relies solely on historical data without considering patient-specific factors fails to acknowledge the unique biological and physical variations that can impact dose delivery. This overlooks the regulatory expectation for individualized treatment planning and verification. Another incorrect approach, focusing only on the most common error types, demonstrates a lack of comprehensive risk assessment and may leave patients vulnerable to less frequent but potentially severe dosimetry errors. This neglects the principle of thoroughness expected in clinical decision-making. Furthermore, an approach that prioritizes speed over accuracy in dose verification, without a clear rationale for the acceptable margin of error, directly contravenes the ethical imperative to provide the best possible care and the implicit regulatory requirement for diligent practice. The professional decision-making process in such situations should involve a structured risk assessment methodology. This begins with identifying potential hazards related to dosimetry, e.g., beam calibration errors, patient positioning inaccuracies, treatment planning system uncertainties. Subsequently, the likelihood and severity of each hazard are evaluated to determine the overall risk. Based on this assessment, appropriate control measures are implemented, such as rigorous quality assurance protocols, independent dose checks, and patient-specific verification procedures. Continuous monitoring and reevaluation of risks are crucial to adapt to evolving clinical scenarios and technological advancements, ensuring ongoing compliance with best practices and regulatory expectations. Question 3. Benchmark analysis indicates that, while advanced imaging techniques can enhance target delineation in radiation oncology, there is a growing concern regarding the cumulative radiation dose delivered to patients during the diagnostic workup and treatment planning phases. A radiation oncologist is planning treatment for a patient with a localized malignancy. The treatment planning system requires accurate visualization of the tumor and surrounding critical organs. Considering the ALARA principle, which of the following approaches best reflects responsible practice in this scenario? Option A. Select an imaging protocol that provides diagnostically adequate information for treatment planning, with dose levels optimized to be as low as reasonably achievable, considering the clinical requirements and available technology. Option B. Opt for an imaging modality that is known to deliver a significantly higher radiation dose, but is perceived to offer superior image quality, even if the additional quality does not substantially improve treatment planning accuracy. Option C. Utilize the highest resolution imaging protocol available to ensure the most precise delineation of the target volume and critical structures, regardless of the associated radiation dose. Option D. Employ a standard imaging protocol that has been historically used for similar cases, without further investigation into dose optimization for this specific patient. The correct answer is C. Utilize the highest resolution imaging protocol available to ensure the most precise delineation of the target volume and critical structures, regardless of the associated radiation dose. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology, where the need to acquire diagnostic imaging for treatment planning must be balanced against the principle of ALARA, as low as reasonably achievable. The professional challenge lies in determining the optimal imaging technique that provides sufficient diagnostic information for accurate dose calculation and treatment delivery, while minimizing radiation exposure to the patient and staff. This requires a nuanced understanding of imaging physics, radiation biology, and regulatory requirements. Correct approach analysis. The correct approach prioritizes patient safety and adherence to the ALARA principle by selecting an imaging modality and protocol that delivers the lowest acceptable radiation dose for the diagnostic information required. This aligns with the fundamental principles of radiation protection as mandated by Indian regulatory frameworks governing the use of ionizing radiation in medical practice. The focus is on justification. Is the procedure necessary? Optimization is the dose as low as reasonably achievable, and dose limitation is the dose within prescribed limits. Choosing a technique that provides adequate visualization of the target volume and critical structures without unnecessary exposure is paramount. Incorrect approach is analysis. An approach that solely focuses on obtaining the highest possible image resolution without considering the radiation dose is unacceptable. This violates the ALARA principle by not optimizing the dose for the diagnostic task. Regulatory guidelines emphasize that dose should be justified by the diagnostic benefit and optimized to be as low as reasonably achievable. Another incorrect approach would be to use a standard imaging protocol without any modification, even if a lower dose alternative is known to be diagnostically sufficient for the specific clinical situation. This fails to actively optimize the dose and may lead to unnecessary exposure. Selecting an imaging technique that is known to deliver significantly higher doses for a similar diagnostic outcome without a clear clinical justification for the increased dose is also a failure to adhere to ALARA and regulatory expectations. Professional reasoning. Professionals must adopt a systematic decision-making process. This involves 1. Clearly defining the diagnostic information required for treatment planning. 2. Evaluating available imaging modalities and their associated radiation doses. 3. Selecting the modality and protocol that best balances diagnostic quality with radiation dose, always striving for optimization. 4. Documenting the rationale for the chosen imaging technique, particularly if it deviates from standard protocols or involves a higher dose for a specific clinical reason. This ensures accountability and continuous improvement in radiation protection practices. Question 4. Governance review demonstrates that a patient's glioblastoma multiforme, treated with standard fractionated radiotherapy, has shown a suboptimal response despite accurate dose delivery and adherence to treatment protocols. Considering the fundamental principles of radiation biology as emphasized in the Diplomate of National Board in Radiation Oncology curriculum, which of the following factors is most likely to have significantly influenced the observed radiosensitivity of the tumor? Option A. Deviations in the patient's daily positioning during treatment sessions. Option B. The specific brand of linear accelerator used for treatment delivery. Option C. The degree of tumor hypoxia and the predominant cell cycle phases of the tumor cells at the time of irradiation. Option D. The patient's dietary habits and fluid intake during the course of therapy. The correct answer is C. The degree of tumor hypoxia and the predominant cell cycle phases of the tumor cells at the time of irradiation. Explanation. Scenario analysis. This scenario presents a common clinical challenge where a patient's tumor exhibits an unexpected response to radiation therapy, prompting a review of treatment parameters. The professional challenge lies in accurately attributing the observed response to underlying biological factors, specifically radiosensitivity, and then translating this understanding into appropriate clinical adjustments or future treatment planning. This requires a deep understanding of radiobiology principles and their practical application within the Indian regulatory framework for radiation oncology. Correct approach analysis. The correct approach correctly identifies that variations in tumor oxygenation and the cell cycle phase of tumor cells at the time of irradiation are fundamental determinants of radiosensitivity. Hypoxia, low oxygen, significantly reduces the effectiveness of radiation by impairing the formation of permanent DNA damage, a key mechanism of cell killing. Similarly, cells in different phases of the cell cycle have varying sensitivities, with the S phase generally being the most radioresistant and the M and G2 phases being more sensitive. Understanding these factors allows for a more precise assessment of why a tumor might be less responsive than anticipated and guides potential strategies like dose escalation, altered fractionation, or the use of radiosensitizing agents, all within the purview of established DNB radiation oncology guidelines. Incorrect approaches analysis. One incorrect approach might focus solely on technical aspects of radiation delivery, such as beam alignment or dose calibration, without considering the biological response. This fails to address the root cause of differential radiosensitivity and represents a significant lapse in clinical judgment, potentially leading to suboptimal patient outcomes and contravening the DNB curriculum's emphasis on understanding radiobiological principles. Another incorrect approach could involve empirical dose escalation without a clear radiobiological rationale. While dose escalation might be considered, doing so without understanding the specific factors limiting radiosensitivity, like hypoxia or cell cycle status, is not evidence-based and could lead to increased toxicity without commensurate benefit, violating the principles of responsible radiation oncology practice as expected in DNB training. A third incorrect approach might dismiss the observed response as an anomaly without further investigation. This demonstrates a lack of critical thinking and a failure to learn from clinical observations, which is contrary to the continuous learning and evidence-based practice promoted by the National Board of Examinations. It neglects the opportunity to refine treatment strategies based on individual tumor biology. Professional reasoning. Professionals should approach such scenarios by first acknowledging the observed clinical outcome. They should then systematically consider the known radiobiological factors influencing treatment response, such as tumor microenvironment, including oxygenation, and cellular kinetics cell cycle. This systematic evaluation, guided by the principles taught in the DNB radiation oncology curriculum, allows for the identification of potential reasons for the observed response. Based on this analysis, appropriate clinical decisions can be made, which may include further investigation, treatment modification, or consultation with colleagues. This iterative process of observation, analysis, and action is crucial for optimizing patient care and adhering to the highest standards of the profession. Question 5. Research into the most appropriate method for routine output calibration verification of a linear accelerator in a hospital setting in India, considering the need for accuracy, traceability to national standards, and compliance with Indian regulatory guidelines for radiation oncology. Option A. Using a personal dosimeter to estimate the machine's output. Option B. Relying solely on the machine's internal dosimetry system without independent verification. Option C. Utilizing a calibrated ion chamber traceable to the National Physical Laboratory, NPL, India for absolute dose calibration. Option D. Employing a survey meter that has not undergone recent calibration by an accredited Indian calibration laboratory. The correct answer is C. Utilizing a calibrated ion chamber traceable to the National Physical Laboratory, NPL, India for absolute dose calibration. Explanation. This scenario presents a professional challenge due to the critical need for accurate and reliable radiation measurement in a clinical setting, directly impacting patient safety and treatment efficacy. The National Board of Examinations Diplomate of National Board in Radiation Oncology, India, mandates adherence to stringent guidelines for radiation measurement to ensure consistency and quality in radiation oncology practice. The challenge lies in selecting the most appropriate method for verifying the output of a linear accelerator, considering factors like accuracy, traceability, and regulatory compliance within the Indian context. The correct approach represents best professional practice because it aligns with the principles of quality assurance and patient safety, as enshrined in Indian regulatory frameworks governing medical radiation. Specifically, it emphasizes the use of calibrated instruments traceable to national standards, ensuring that the measured dose accurately reflects the intended therapeutic dose. This approach is crucial for maintaining the integrity of treatment plans and preventing under- or overdosing of patients, which are direct violations of ethical and professional responsibilities. An incorrect approach that relies on uncalibrated or non-traceable instruments fails to meet the fundamental requirements for radiation measurement in India. Such a practice poses a significant ethical failure by compromising patient safety and a regulatory failure by not adhering to the prescribed standards for medical equipment verification. Another incorrect approach might involve relying solely on manufacturer specifications without independent verification. This is professionally unacceptable, as it bypasses the essential independent quality assurance checks mandated to ensure the accuracy and reliability of the radiation output, potentially leading to treatment errors. A further incorrect approach could be to use a method that is not recognized or validated by Indian regulatory bodies for clinical dosimetry, thereby introducing uncertainty and noncompliance. The professional decision-making process for similar situations should involve a systematic evaluation of available measurement techniques against established Indian regulatory guidelines, such as those provided by the Atomic Energy Regulatory Board (AERB) or relevant professional bodies. Professionals must prioritize methods that offer traceability to national standards, demonstrate accuracy and precision, and are recognized for clinical dosimetry. This involves understanding the limitations of different measurement devices and techniques, and selecting the one that best ensures patient safety and treatment quality within the legal and ethical framework of radiation oncology practice in India. Question 6. The risk matrix shows a low likelihood, moderate impact event related to a minor deviation in the daily QA checks for a linear accelerator. The deviation, while not immediately compromising patient safety, suggests a potential for drift in machine performance over time. What is the most appropriate immediate action to ensure radiation safety and regulatory compliance? Option A. Attempt to recalibrate the machine independently without consulting the radiation safety officer or documenting the deviation to quickly resolve the issue. Option B. Immediately involve the radiation safety officer to conduct a thorough investigation, assess the actual risk to patients and staff, and determine necessary corrective and preventive actions, while continuing patient treatments with increased vigilance. Option C. Immediately halt all patient treatments on the affected linear accelerator until the deviation is fully understood and rectified, regardless of the assessed impact. Option D. Continue with scheduled patient treatments as usual, assuming the deviation is minor and unlikely to cause harm, and address it during the next scheduled maintenance. The correct answer is B. Immediately involve the radiation safety officer to conduct a thorough investigation, assess the actual risk to patients and staff, and determine necessary corrective and preventive actions, while continuing patient treatments with increased vigilance. Explanation. This scenario presents a common challenge in radiation oncology where a potential safety deviation is identified, requiring a structured approach to risk assessment and mitigation. The professional challenge lies in balancing the need for timely patient care with the imperative of maintaining radiation safety standards as mandated by Indian regulatory frameworks, specifically those overseen by the Atomic Energy Regulatory Board (AERB), and relevant guidelines for medical institutions. A careful judgment is required to determine the appropriate level of response without causing undue disruption or compromising patient safety. The correct approach involves a systematic risk assessment that prioritizes patient and staff safety while ensuring compliance with established protocols. This aligns with the principles of radiation protection, emphasizing ALARA as low as reasonably achievable and the need for robust quality assurance. By involving the radiation safety officer, RSO, and conducting a thorough investigation, the team adheres to the regulatory requirement for reporting and addressing safety incidents, ensuring that corrective actions are implemented based on a comprehensive understanding of the risk. This proactive and systematic method represents best professional practice because it is grounded in the principles of radiation safety management and regulatory compliance, aiming to prevent recurrence and uphold the highest standards of care. An incorrect approach would be to dismiss the observation without proper investigation. This failure stems from a disregard for the potential for even minor deviations to escalate into significant safety breaches, violating the spirit of ALARA and the regulatory expectation for diligent oversight. Another incorrect approach would be to immediately halt all treatments without a proper risk assessment. This demonstrates a lack of nuanced judgment and could lead to unnecessary patient anxiety and disruption of care, failing to apply a proportionate response based on the assessed risk. Finally, attempting to rectify the issue without involving the RSO or documenting the process bypasses crucial regulatory and quality assurance mechanisms, undermining accountability and the systematic improvement of safety protocols. The professional decision-making process for similar situations should involve 1. Immediate identification and reporting of any potential safety concern. 2. A structured risk assessment, considering the likelihood and severity of harm. 3. Consultation with the radiation safety officer and relevant stakeholders. 4. Implementation of appropriate, proportionate corrective and preventive actions. 5. Thorough documentation of the incident, assessment, and actions taken. 6. Regular review and auditing of safety procedures. Question 7. Process analysis reveals a significant discrepancy between the planned dose delivered to a patient and the actual measured output from the linear accelerator during routine quality assurance checks. The physicist reports a consistent underdelivery of 5% across all energy levels. The radiation oncologist is informed of this finding. Which of the following represents the most appropriate immediate course of action to ensure patient safety and regulatory compliance? Option A. Immediately halt all treatments on the affected linear accelerator until the cause of the discrepancy is identified and rectified, and independently verify the machine's output with a calibrated phantom. Option B. Instruct the physicist to recheck the treatment planning system calculations to ensure no errors were made in dose prescription. Option C. Continue treatments as planned, assuming the 5% underdelivery is within acceptable clinical margins, and schedule a comprehensive machine calibration for the following week. Option D. Proceed with treatments but adjust the prescribed dose for each patient by adding 5% to compensate for the machine's underdelivery, pending further investigation. The correct answer is A. Immediately halt all treatments on the affected linear accelerator until the cause of the discrepancy is identified and rectified, and independently verify the machine's output with a calibrated phantom. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology, where a discrepancy arises between planned dose delivery and actual measured output from a linear accelerator. The professional challenge lies in ensuring patient safety and treatment efficacy while adhering to stringent quality assurance protocols and regulatory requirements. The physician must critically evaluate the potential causes of the discrepancy, prioritize patient well-being, and implement corrective actions in a timely and documented manner, all within the framework of the National Board of Examinations, Diplomate of National Board in Radiation Oncology, India. Guidelines. Correct approach analysis. The correct approach involves a systematic and thorough investigation of the discrepancy, starting with immediate verification of the machine's output, and then proceeding to a comprehensive review of the treatment plan and patient-specific factors. This aligns with the principles of radiation safety and quality assurance mandated by regulatory bodies. Specifically, it emphasizes the importance of independent verification of machine parameters and treatment delivery, which is a cornerstone of safe radiation oncology practice. The immediate cessation of treatment until the discrepancy is resolved ensures that no patient receives an unintended dose, thereby upholding the ethical obligation to do no harm. Documentation of all steps taken is crucial for regulatory compliance and for future reference. Incorrect approach is analysis. Continuing treatment without immediate verification of the machine output is a direct violation of radiation safety principles and regulatory guidelines. This approach risks delivering a non-prescribed dose to the patient, which could lead to undertreatment, treatment failure, or overtreatment, toxicity. It demonstrates a failure to adhere to quality assurance protocols designed to prevent such occurrences. Assuming the discrepancy is minor and proceeding with treatment while planning a later investigation is also unacceptable. Radiation doses are precisely calculated, and even small deviations can have significant clinical consequences over the course of a treatment course. This approach prioritizes expediency over patient safety and regulatory compliance, Focusing solely on the treatment plan without verifying the machine's output is incomplete. While treatment plan errors can occur, a machine output discrepancy is a fundamental issue that must be addressed first, as it affects the delivery of all plans. This approach fails to address the most immediate and potentially dangerous cause of the observed difference: professional reasoning. In situations involving potential deviations in radiation dose delivery, the professional decision-making process should follow a hierarchical approach prioritizing patient safety and regulatory adherence. First, immediately halt any treatment that might be affected. Second, independently verify the machine's output using established protocols and phantoms. Third, if the machine output is confirmed to be outside acceptable tolerances, initiate immediate corrective actions and recalibration. Fourth, if the machine output is within tolerance, then meticulously review the treatment plan, patient positioning, and delivery parameters for any errors. Throughout this process, thorough documentation of all findings, actions, and communications is paramount. This systematic approach ensures that patient care is not compromised and that all regulatory requirements are met. Question 8. Which approach would be most appropriate for a radiation oncologist when a patient's biopsy reveals an unusual cellular morphology that is not readily identifiable and may have implications for radiation sensitivity, but definitive molecular characterization will take several weeks? Option A. Postpone radiation therapy indefinitely until complete and definitive molecular profiling of the abnormal cells is obtained, regardless of the potential for disease progression. Option B. Proceed with the originally planned radiation therapy regimen without further investigation, assuming the cellular abnormality is not clinically significant enough to alter the treatment strategy. Option C. Immediately escalate to highly aggressive, experimental radiation techniques and systemic therapies without a clear understanding of the cellular abnormality's radiobiological significance. To err on the side of caution, Option D. Conduct a thorough review of the patient's existing clinical data, imaging, and pathology reports. Perform a comprehensive literature search for similar cellular presentations and their radiobiological implications. Consult with a pathologist or molecular biologist for expert opinion, and then formulate a treatment plan based on the integrated information and a reasoned hypothesis about the cellular abnormality's impact. The correct answer is D. Conduct a thorough review of the patient's existing clinical data, imaging, and pathology reports. Perform a comprehensive literature search for similar cellular presentations and their radiobiological implications. Consult with a pathologist or molecular biologist for expert opinion, and then formulate a treatment plan based on the integrated information and a reasoned hypothesis about the cellular abnormality's impact. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology, where a patient's treatment plan is based on an understanding of cellular radiobiology. The challenge lies in accurately assessing the impact of a newly identified cellular abnormality on treatment efficacy and toxicity, especially when it deviates from typical presentations. The physician must balance the need for evidence-based decision-making with the practical limitations of immediate, definitive cellular characterization in a clinical setting. This requires a deep understanding of cell structure and function, and how these can be affected by disease and radiation. Correct approach analysis. The correct approach involves a comprehensive review of the patient's existing clinical data, imaging, and pathology reports to identify any subtle clues or patterns that might explain the observed cellular morphology. This is followed by a thorough literature search for similar cellular presentations and their known radiobiological implications. Consulting with a pathologist or molecular biologist for their expert opinion on the potential functional significance of the abnormal cells is crucial. Finally, integrating this information to formulate a hypothesis about the cellular abnormality's impact on radiation sensitivity or resistance, and then adjusting the treatment plan based on this informed hypothesis, represents best professional practice. This approach aligns with the principles of evidence-based medicine and patient-centered care, emphasizing a systematic and collaborative approach to complex clinical problems, as expected within the framework of medical practice governed by the National Board of Examinations. It prioritizes patient safety and optimal outcomes by seeking to understand the underlying biological basis of the observed phenomenon before making definitive treatment decisions. Incorrect approach is analysis, One incorrect approach is to proceed with the original treatment plan without further investigation, assuming the cellular abnormality is clinically insignificant. This fails to acknowledge the potential impact of altered cell structure and function on treatment response and toxicity, potentially leading to suboptimal outcomes or unnecessary harm. It disregards the physician's responsibility to critically evaluate all available patient information and adapt treatment accordingly, a core tenet of medical ethics and professional conduct. Another incorrect approach is to immediately escalate to highly aggressive, unproven treatment modalities based solely on the unusual cellular finding, without a clear understanding of its radiobiological implications. This is premature and potentially dangerous, as it bypasses the necessary steps of differential diagnosis and evidence gathering. It can lead to overtreatment, increased toxicity, and failure to address the actual underlying issue, violating the principle of do no harm and the requirement for judicious application of therapeutic interventions. A third incorrect approach is to delay treatment indefinitely while awaiting definitive, time-consuming molecular profiling of the abnormal cells. While comprehensive analysis is valuable, radiation oncology often requires timely intervention. Unnecessary delays can allow disease progression, compromising the potential for cure or effective palliation, and may not be in the patient's best interest, especially if a reasonable clinical hypothesis can be formed and acted upon. This approach fails to balance the pursuit of perfect information with the urgency of clinical need. Professional reasoning. Professionals facing such a situation should employ a structured decision-making process. First, thoroughly gather and review all available clinical and pathological data. Second, formulate differential diagnoses for the observed cellular abnormality, considering its potential impact on radiobiology. Third, conduct targeted literature reviews and consult with relevant specialists, pathology, molecular biology, to gather expert opinions and evidence. Fourth, weigh the potential benefits and risks of different treatment strategies based on the synthesized information. Fifth, communicate the uncertainties and proposed plan clearly to the patient, involving them in the decision-making process. This systematic approach ensures that decisions are informed, ethical, and patient-centered, adhering to the high standards expected in radiation oncology. Question 9. The review process indicates a patient presenting with dysphagia 6 months after completing definitive chemoradiotherapy for locally advanced squamous cell carcinoma of the esophagus. The patient denies any recent weight loss or fever. Considering the typical timeline for radiation-induced sequelae, which of the following is the most likely primary etiology for the dysphagia? Option A. Esophageal candidiasis. Option B. Radiation-induced fistula. Option C. Acute radiation esophagitis. Option D. Radiation-induced esophageal stricture. The correct answer is D. Radiation-induced esophageal stricture. Explanation. The review process indicates a need to assess the understanding of radiation effects in the context of patient management, specifically differentiating between early and late sequelae. This scenario is professionally challenging because it requires the clinician to apply theoretical knowledge of radiation biology to a practical clinical situation, where the timing of symptoms is crucial for accurate diagnosis and appropriate management. Misinterpreting the nature of radiation-induced effects can lead to delayed or incorrect treatment, potentially impacting patient outcomes and adherence to established clinical guidelines. The correct approach represents best professional practice because it demonstrates a thorough understanding of radiation oncology principles, aligning with the expected competencies for a diplomate of national board in radiation oncology. It prioritizes accurate diagnosis based on the temporal relationship between radiation exposure and symptom onset, which is a cornerstone of differentiating between acute and chronic radiation toxicity. This aligns with the ethical imperative to provide evidence-based and patient-centered care, ensuring that management strategies are tailored to the specific nature of the observed effects. Adherence to these principles is implicitly expected within the regulatory framework governing medical practice in India, emphasizing competence and patient welfare. An incorrect approach that focuses solely on the presence of symptoms without considering their timing fails to acknowledge the fundamental distinction between early and late radiation effects. This represents a significant regulatory and ethical failure, as it can lead to misdiagnosis, inappropriate investigations, and potentially harmful interventions. For instance, treating a late effect as an acute one might involve interventions that are not indicated, and could even exacerbate the condition. Another incorrect approach that attributes all post-treatment symptoms to radiation without considering other potential etiologies is also professionally unacceptable. This demonstrates a lack of differential diagnosis skills and can lead to unnecessary patient anxiety and resource utilization, violating the principle of prudent medical practice. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's clinical presentation, including a detailed history of the radiation treatment, dose, volume, fractionation, the onset and progression of symptoms, and the exclusion of other potential causes. This structured approach ensures that management decisions are based on a comprehensive understanding of the patient's condition and the principles of radiation oncology, thereby upholding the highest standards of patient care and professional responsibility, as expected within the Indian medical regulatory landscape. Question 10. The analysis reveals that a radiation oncology department is preparing to adopt a new national guideline for the management of locally advanced cervical cancer. This guideline emphasizes specific dose constraints for organs at risk and mandates a particular frequency for image-guided radiotherapy (IGRT) verification. Which of the following actions best demonstrates adherence to the regulatory standards and guidelines for radiation oncology in India during this transition? Option A. The department proceeds with implementing the new guideline using existing treatment planning parameters and relies on the clinical judgment of the radiation oncologists to manage organs at risk, while continuing IGRT verification at the previously established frequency. Option B. The department informs the medical staff about the new guideline via email and instructs them to consult the document independently, assuming that the existing quality assurance framework is adequate for the new protocol. Option C. The department updates its treatment planning system to incorporate the new dose constraints and schedules a mandatory in-service training session for all radiation oncologists and medical physicists on the revised IGRT protocols before commencing patient treatments under the new guideline. Option D. The department prioritizes treating patients according to the new guideline immediately, with plans to review and update the treatment planning system and conduct staff training in the subsequent quarter. The correct answer is C. The department updates its treatment planning system to incorporate the new dose constraints and schedules a mandatory in-service training session for all radiation oncologists and medical physicists on the revised IGRT protocols before commencing patient treatments under the new guideline. Explanation. The analysis reveals a scenario where a radiation oncology department is implementing a new treatment protocol for a common malignancy. The challenge lies in ensuring that the implementation adheres strictly to the regulatory standards and guidelines set forth by the National Board of Examinations for Radiation Oncology in India, specifically concerning patient safety, quality assurance, and documentation. Professionals must navigate the complexities of translating theoretical guidelines into practical, everyday clinical workflows. The correct approach involves a comprehensive review and adaptation of the existing departmental policies and procedures to align with the latest regulatory requirements. This includes updating treatment planning systems, ensuring staff training on new protocols, and establishing robust quality assurance checks at each stage of patient care, from simulation to follow-up. This meticulous adherence to regulatory standards is paramount for patient safety, as it minimizes the risk of errors and ensures that treatment is delivered consistently and effectively, as mandated by the governing body. It also ensures compliance with the legal and ethical obligations of the institution and its practitioners. An incorrect approach would be to assume that existing protocols are sufficient without a formal review against the new guidelines. This failure to proactively assess and adapt can lead to subtle deviations from mandated standards, potentially compromising patient care and leading to regulatory noncompliance. Another incorrect approach is to prioritize speed of implementation over thoroughness, skipping essential steps like staff training or comprehensive quality assurance checks. This haste can result in overlooked errors and a lack of understanding of the new protocol's nuances, directly contravening the spirit and letter of regulatory requirements designed to protect patients. Finally, neglecting to update documentation practices to reflect the new protocol's requirements would be a significant oversight, as accurate and complete records are a cornerstone of regulatory compliance and are essential for auditing and accountability. The professional decision-making process in such situations should involve a systematic approach. First, a thorough understanding of the specific regulatory requirements. Second, a gap analysis between current practices and mandated standards. Third, the development of a detailed implementation plan that includes training, protocol adaptation, and quality assurance mechanisms. And fourth, ongoing monitoring and evaluation to ensure sustained compliance and patient safety. Question 11. Market research demonstrates that understanding the fundamental principles of radiation interaction with matter is critical for accurate treatment planning in radiation oncology. Considering the typical megavoltage photon beams used in modern radiotherapy, which of the following best describes the primary interaction mechanism responsible for dose deposition in biological tissues and its implications for treatment planning? Option A. Pair production is the most significant interaction, where photons create electron-positron pairs, influencing dose distribution in high-energy beams and requiring specific shielding considerations. Option B. Compton scattering is the dominant interaction, leading to energy transfer to electrons and subsequent ionization, requiring careful consideration of electron transport and scatter contributions in dose calculations. Option C. Rayleigh scattering is the dominant interaction, causing a change in photon direction without energy loss, which has minimal impact on dose deposition and can be largely ignored in treatment planning. Option D. The photoelectric effect is the primary interaction, resulting in the absorption of photons and emission of characteristic X-rays, necessitating precise control of beam energy to minimize tissue damage. The correct answer is B. Compton scattering is the dominant interaction, leading to energy transfer to electrons and subsequent ionization, requiring careful consideration of electron transport and scatter contributions in dose calculations. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology practice where a physician must interpret complex physical phenomena, interaction of radiation with matter, to optimize patient treatment. The challenge lies in translating fundamental physics principles into practical clinical decisions, ensuring both efficacy and safety within the established regulatory framework of the National Board of Examinations for Radiation Oncology in India. The physician needs to demonstrate a deep understanding of how different radiation types interact with biological tissues and treatment planning systems, and how these interactions influence dose delivery and potential side effects. This requires not just theoretical knowledge, but also the ability to apply it judiciously in a patient-specific context, adhering to the standards of care and ethical considerations mandated by the Indian regulatory environment for medical professionals. Correct approach analysis. The correct approach involves a thorough understanding of the photoelectric effect and Compton scattering, and their relative dominance at different photon energies. This knowledge is crucial for accurately predicting how a megavoltage photon beam will interact with the patient's tissues and the treatment planning system's phantom materials. Specifically, recognizing that Compton scattering is the dominant interaction mechanism for megavoltage photons used in radiotherapy e.g., cobalt-60 or linear accelerators is fundamental. This understanding allows for more accurate dose calculations, better prediction of dose distribution, and informed decisions regarding treatment planning parameters. This aligns with the National Board of Examinations' emphasis on a strong foundation in radiation physics, which is essential for safe and effective radiation oncology practice in India. Adherence to established physics principles ensures that treatment plans are based on sound scientific understanding, directly contributing to patient safety and treatment efficacy, which are paramount in the Indian healthcare context. Incorrect approaches analysis. One incorrect approach would be to overemphasize the photoelectric effect for megavoltage photon beams. The photoelectric effect is more significant at lower photon energies and is primarily responsible for interactions in denser materials or at lower kV energies. In megavoltage radiotherapy, its contribution to dose deposition in soft tissue is minimal compared to Compton scattering. Relying on this incorrect assumption would lead to flawed dose calculations and potentially suboptimal treatment planning, violating the principle of providing evidence-based and technically sound care as expected by the National Board of Examinations. Another incorrect approach would be to disregard the energy dependence of radiation-matter interactions altogether. This would mean treating all photon interactions as uniform, irrespective of the beam energy. Such an approach ignores a critical physical principle that directly impacts dose distribution and biological effect. This lack of nuanced understanding would lead to inaccurate dose predictions, potentially resulting in under- or overtreatment, which is a direct contravention of the safety and efficacy standards expected of a diplomate of National Board in Radiation Oncology in India. A third incorrect approach would be to solely focus on the interaction mechanisms in the treatment planning system's phantom material, without considering the differences in elemental composition and density compared to human tissues. While phantom data is used for calibration, the actual dose delivered to the patient is determined by how radiation interacts with their specific biological tissues. Failing to account for these differences, which are governed by the fundamental interaction physics, would lead to inaccurate patient dose estimations and compromised treatment outcomes. A failure to uphold the highest standards of patient care mandated by the regulatory body. Professional reasoning. Professionals should approach such scenarios by first identifying the core physics principle at play and its relevance to the clinical situation. It must then recall and apply the specific characteristics of that interaction, particularly its energy dependence. This involves consulting established physics textbooks and guidelines relevant to radiation oncology, which are implicitly part of the knowledge base tested by the National Board of Examinations. The decision-making process should involve a systematic evaluation of how different interaction mechanisms influence dose deposition and distribution in the patient. This requires a continuous learning mindset, staying updated with advancements in radiation physics and their clinical implications, and critically assessing the assumptions made in treatment planning. The ultimate goal is to ensure that all treatment decisions are grounded in a robust understanding of radiation-matter interactions, leading to safe, effective, and ethically sound patient care within the Indian regulatory framework. Question 12. Operational review demonstrates that for a new patient undergoing stereotactic radiosurgery, SRS, for a brain metastases, the treatment plan has been finalized by the radiation oncologist and the dosimetrist. The patient is scheduled for the first fraction of treatment tomorrow. What is the most critical next step to ensure patient safety and regulatory compliance? Option A. Independent verification of the complete treatment plan, including dose distribution, beam parameters, and patient-specific QA, by a qualified medical physicist before the first fraction is delivered. Option B. Initiate patient setup and imaging verification for the first fraction, with the understanding that the physics plan check will be completed post-delivery. Option C. Schedule a follow-up consultation with the radiation oncologist to discuss potential adjustments to the plan based on initial patient response. Option D. Proceed with treatment delivery as scheduled, assuming the radiation oncologist's and dosimetrist's review is sufficient. Correct answer is A. Independent verification of the complete treatment plan, including dose distribution, beam parameters, and patient-specific QA, by a qualified medical physicist before the first fraction is delivered. Explanation. This scenario presents a professional challenge due to the inherent complexities of stereotactic radiosurgery, SRS, and stereotactic body radiotherapy, SBRT. These techniques demand extreme precision in targeting and dose delivery, necessitating robust quality assurance, CA protocols, to ensure patient safety and treatment efficacy. The challenge lies in balancing the need for efficient workflow with the non-negotiable requirement for meticulous verification at critical junctures. The correct approach represents best professional practice because it aligns with the fundamental principles of radiation oncology, emphasizing patient safety and adherence to established QA standards. Specifically, it reflects the Indian regulatory framework's emphasis on independent verification of critical treatment parameters before delivery. This proactive approach minimizes the risk of errors that could lead to significant patient harm, such as under- or overdosing, or delivery to an incorrect target. The regulatory expectation is for a multi-layered safety net, where each critical step is validated by qualified personnel. An incorrect approach that bypasses independent verification of the treatment plan by a qualified medical physicist before the first fraction of SRS/SBRT is professionally unacceptable. This constitutes a direct violation of established QA protocols and implicitly disregards the regulatory emphasis on independent checks. Such an oversight creates a significant risk of delivering an erroneous treatment, potentially leading to severe adverse events for the patient. The ethical failure lies in compromising patient safety by circumventing a crucial safety checkpoint. Another incorrect approach that relies solely on the treating radiation oncologist's review of the plan without a separate, independent physics review before treatment initiation is also professionally flawed. While the radiation oncologist is responsible for the clinical decision-making, the technical aspects of dose calculation, beam arrangement, and delivery verification require specialized physics expertise. Failing to obtain this independent physics verification before the first fraction represents a gap in the QA process, increasing the likelihood of undetected errors. This can be seen as a failure to adhere to best practices for ensuring treatment accuracy and safety, as expected by regulatory bodies. The professional decision-making process for similar situations should involve a systematic risk assessment at each stage of SRS/SBRT treatment planning and delivery. This includes 1. Identifying critical steps where errors could have significant consequences, e.g., plan verification, patient setup, dose delivery. 2. Establishing clear protocols for independent verification at these critical steps, involving appropriate personnel, radiation oncologist, medical physicist, dosimetrist. 3. Ensuring that all QA procedures are documented and auditable. 4. Fostering a culture of safety, where team members feel empowered to raise concerns and halt treatment if any doubt exists regarding the accuracy or safety of the planned or delivered radiation. This systematic approach ensures that patient safety remains paramount and that all regulatory requirements are met. Question 13. During the evaluation of the output calibration of a new 6MV linear accelerator, which dosimetric approach, when implemented without rigorous adherence to established calibration protocols and without considering the specific energy characteristics of the beam, would pose the greatest risk to accurate dose delivery and patient safety according to Indian regulatory frameworks? Option A. Employing ionization chambers calibrated by a reputable, accredited laboratory traceable to national standards. Option B. Using OSLs for routine output checks after initial calibration with a primary standard dosimeter. Option C. Utilizing TLDs for absolute dose calibration without accounting for their energy dependence and ensuring traceability to primary standards. Option D. Relying on a well-maintained electrometer with a calibrated ionization chamber that has a current calibration certificate. The correct answer is C. Utilizing TLDs for absolute dose calibration without accounting for their energy dependence and ensuring traceability to primary standards. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology departments, ensuring the accuracy and reliability of radiation dose measurements. The choice and proper use of dosimeters are fundamental to patient safety and treatment efficacy. A failure in this area can lead to under- or overdosing, with potentially severe clinical consequences. The professional challenge lies in selecting the most appropriate dosimeter for a given task, understanding its limitations, and ensuring its calibration and handling comply with established standards, as mandated by regulatory bodies overseeing medical physics and radiation oncology practices in India. Correct approach analysis. The correct approach involves selecting a dosimeter that is appropriate for the specific measurement task, considering factors like energy dependence, sensitivity, and the required precision, and ensuring it is calibrated according to the guidelines set by the Atomic Energy Regulatory Board, AERB, or other relevant Indian authorities. For routine quality assurance of linear accelerators and brachytherapy sources, ionization chambers are often the gold standard due to their established accuracy, wide energy response, and traceability to national standards. Their use in conjunction with calibrated electrometers provides reliable absolute dosimetry. The emphasis on calibration and adherence to established protocols directly aligns with the AERB directives on radiation safety and quality assurance in medical facilities, ensuring that treatments are delivered as prescribed and patient safety is paramount. Incorrect approach is analysis. One incorrect approach would be to solely rely on TLDs for absolute dose calibration of a high-energy photon beam without proper energy and depth correction factors, or without ensuring their traceability to a primary standard. While TLDs are excellent for relative dosimetry, patient dosimetry, and long-term dose monitoring, due to their small size and tissue equivalence, their inherent energy dependence, and the need for complex readout and calibration procedures make them less ideal for primary absolute dose calibration compared to ionization chambers. This failure to use the most appropriate dosimeter for the task and to ensure proper calibration would violate principles of accurate dose delivery and quality assurance. Another incorrect approach would be to use OSLs for routine output calibration of a linear accelerator, without understanding their specific energy response characteristics, and without a robust calibration protocol. OSLs offer advantages in terms of ease of use and rereadability, but their response can be influenced by factors like dose rate and beam quality, requiring careful validation for absolute dosimetry. Using them without this understanding and validation would compromise the accuracy of the delivered dose and potentially deviate from ARB guidelines on dosimetry accuracy. A third incorrect approach would be to assume that any dosimeter, regardless of its type or calibration status, will provide accurate results for all clinical applications. This demonstrates a fundamental misunderstanding of dosimetric principles and regulatory requirements. Each dosimeter type has specific strengths, weaknesses, and calibration needs. Ignoring these, or failing to adhere to the calibration schedules and procedures mandated by Indian regulatory bodies, constitutes a significant professional and ethical lapse, directly impacting patient safety. Professional reasoning. Professionals in radiation oncology must adopt a systematic approach to dosimeter selection and utilization. This involves 1. Identifying the specific dosimetric task, e.g., absolute dose calibration, relative dosimetry, patient dose verification. 2. Consulting relevant national and international guidelines, e.g., ARB safety codes, i.e. a TRS series, to understand the recommended dosimeters and protocols for that task. 3. Evaluating the characteristics of available dosimeters, energy dependence, sensitivity, accuracy, traceability, in relation to the task requirements. 4. Ensuring that all dosimeters used are properly calibrated by accredited laboratories or traceable to national standards, with calibration certificates readily available. 5. Implementing rigorous quality assurance procedures for dosimeter use, including regular checks and intercomparisons. This decision-making process prioritizes accuracy, patient safety, and regulatory compliance, ensuring that radiation treatments are delivered with the highest possible fidelity. Question 14. The evaluation methodology shows a need to optimize radiation therapy for a patient with a localized head and neck squamous cell carcinoma. Considering the radiobiological principles of tumor control and normal tissue complication, which of the following strategies best aligns with maximizing therapeutic gain? Option A. Prioritizing dose escalation to the planning target volume, PTV, without a clear radiobiological rationale for improved tumor control, focusing solely on achieving high physical dose coverage. Option B. Employing radiobiological modeling to predict tumor control probability and normal tissue complication probability for various fractionation schemes, selecting the regimen that offers the most favorable therapeutic ratio. Option C. Ignoring the potential for accelerated tumor repopulation in the treatment planning process, assuming a constant tumor cell kill rate throughout the entire treatment course. Option D. Adhering strictly to standard fractionation schedules previously used for similar cases, without specific radiobiological assessment for this individual patient. The correct answer is B. Employing radiobiological modeling to predict tumor control probability and normal tissue complication probability for various fractionation schemes, selecting the regimen that offers the most favorable therapeutic ratio. Explanation. The evaluation methodology shows a need to optimize radiation therapy planning for a patient with a localized head and neck squamous cell carcinoma, considering radiobiological principles to maximize tumor control while minimizing normal tissue toxicity. The challenge lies in balancing these competing objectives, especially when dealing with sensitive organs at risk or in the head and neck region. Radiobiological models, such as the linear quadratic LQ model, are crucial for predicting treatment outcomes based on dose, fractionation, and tissue sensitivity. The National Board of Examinations Diplomate of National Board in Radiation Oncology, India, emphasizes a thorough understanding of these principles for safe and effective patient care, aligning with the Indian Council of Medical Research, ICMR, guidelines on radiation oncology practices. The correct approach involves utilizing radiobiological modeling to predict tumor control probability, TCP, and normal tissue complication probability, NTCP, for different treatment fractionation schedules. This allows for an informed decision on the optimal dose and fractionation regimen that achieves a favorable therapeutic ratio. This represents best professional practice, as it directly applies established radiobiological principles to personalized treatment, aiming for superior clinical outcomes within acceptable toxicity limits, in accordance with the ethical obligations of a radiation oncologist to provide evidence-based and patient-centered care, as expected by the NBE. An incorrect approach would be to solely rely on historical dose prescriptions, without considering the specific radiobiological characteristics of the tumor and OARs. This fails to leverage modern radiobiological understanding and could lead to suboptimal treatment, either by underdosing the tumor or overdosing critical structures. Another incorrect approach would be to ignore the potential for accelerated repopulation in rapidly dividing tumors, which can significantly impact treatment efficacy if not accounted for in the fractionation schedule. This oversight would violate the principle of providing the most effective treatment possible. A third incorrect approach would be to prioritize dose escalation without a corresponding radiobiological justification for improved TCP, potentially leading to unacceptable NTCP and compromising patient quality of life, which is ethically unsound and contrary to the NBE's focus on patient safety and efficacy. Professionals should approach such scenarios by first comprehensively assessing the clinical and radiobiological parameters of the patient's disease and relevant OARs. This involves reviewing imaging, pathology, and any available radiobiological data. Subsequently, they should employ appropriate radiobiological models to explore various treatment planning options, evaluating the predicted TCP and NTCP for each. The decision-making process should then involve a multidisciplinary discussion, if applicable, and a clear communication of the rationale and potential outcomes to the patient, ensuring informed consent. This systematic, evidence-based, and patient-centric approach is paramount. Question 15. The efficiency study reveals that for a specific patient with a localized, radiosensitive tumor adjacent to a critical organ requiring precise dose delivery, the choice between advanced photon therapy techniques and particle therapy presents a complex decision. Considering the principles of radiation interaction with tissue and established clinical indications within the Indian regulatory framework, which approach best aligns with optimizing therapeutic outcomes while adhering to safety and efficacy standards. Option A. Default to standard photon therapy techniques as they are more widely available and have a well-established track record for most oncological indications in India. Option B. Utilize the highest achievable energy photon beams to ensure maximum tumor penetration, even if it leads to increased dose to surrounding healthy tissues. Option C. Prioritize particle therapy if it offers a superior dose distribution profile that can significantly reduce dose to the critical organ, provided it is available and approved for clinical use by relevant Indian regulatory bodies. Option D. Recommend particle therapy solely based on its advanced technological nature, assuming it will inherently provide better results regardless of specific clinical indications or comparative efficacy data. Correct answer is C. Prioritize particle therapy if it offers a superior dose distribution profile that can significantly reduce dose to the critical organ, provided it is available and approved for clinical use by relevant Indian regulatory bodies. Explanation. This scenario presents a professional challenge due to the need to select the most appropriate radiation modality for a specific clinical scenario, balancing efficacy, patient safety, and resource utilization within the Indian regulatory framework for radiation oncology. The decision hinges on a nuanced understanding of the fundamental differences between particle and electromagnetic radiation, their interaction with biological tissues, and their established clinical applications as governed by the Atomic Energy Regulatory Board, AERB, guidelines, and the Indian Council of Medical Research, ICMR, recommendations. The correct approach involves a thorough evaluation of the patient's specific tumor characteristics, including histology, stage, location, and proximity to critical organs, alongside the known physical and biological properties of different radiation types. This aligns with best professional practice by prioritizing patient benefit and minimizing harm, adhering to the principle of as low as reasonably achievable, ALARA, for radiation dose, and ensuring treatment is delivered according to established protocols and evidence-based medicine. The selection of particle radiation, e.g., protons, for specific indications like pediatric tumors or tumors near critical structures, where its Bragg peak can precisely target the tumor while sparing surrounding healthy tissue, represents a sophisticated application of physics principles to optimize therapeutic outcomes. This is supported by the evolving understanding and integration of advanced technologies within the Indian healthcare system, guided by ARB safety and efficacy standards for radiation-based therapies. An incorrect approach would be to indiscriminately apply electromagnetic radiation, e.g., photons from linear accelerators, to all cases, even when particle therapy offers superior dose distribution and reduced toxicity for specific tumor types. This fails to leverage advancements in radiation oncology and could lead to suboptimal treatment outcomes or unnecessary side effects, potentially contravening the spirit of providing the best available care as implied by national health policies and professional ethical standards. Another incorrect approach would be to advocate for particle therapy solely based on its novelty or perceived technological superiority, without a clear clinical indication or evidence of improved outcomes for the specific patient, ignoring the established efficacy and accessibility of photon therapy for a vast majority of oncological indications. This would represent a failure to conduct a proper clinical assessment and could lead to inefficient resource allocation, a concern within the Indian healthcare context. Furthermore, making a decision without considering the availability and established protocols for each modality within Indian institutions, as guided by ARB and professional bodies, would be a significant regulatory and ethical lapse. The professional reasoning process should involve a multidisciplinary team discussion, including radiation oncologists, medical physicists, and radiation safety officers, to critically assess the clinical scenario against the physical and biological characteristics of available radiation modalities. This process must be informed by the latest ARB guidelines on radiation safety and therapeutic use, ICMR recommendations on cancer management, and relevant peer-reviewed literature. The decision should be patient-centric, evidence-based, and ethically sound, ensuring that the chosen modality offers the best chance of cure or palliation with the least amount of toxicity, within the established regulatory and resource framework of India. Question 16. Regulatory review indicates that understanding the fundamental principles of radiobiology is essential for predicting and managing normal tissue complications in radiation oncology. Considering the linear quadratic LQ model, which of the following best describes its application in assessing the biological effect of different fractionation schedules on normal tissues? Option A. It quantifies the probability of normal tissue complications by relating radiation dose, fractionation, and tissue sensitivity, using alpha and beta parameters to represent cell-killing mechanisms. Option B. It prioritizes tumor control over normal tissue sparing, assuming that any dose escalation for the tumor is acceptable due to the inherent radioresistance of normal tissues. Option C. It relies on empirical observation of past patient outcomes without a theoretical framework, making it difficult to predict responses for novel fractionation schemes. Option D. It solely focuses on the total physical dose delivered to the target volume, assuming all tissues respond uniformly regardless of fractionation. The correct answer is A. It quantifies the probability of normal tissue complications by relating radiation dose, fractionation, and tissue sensitivity, using alpha and beta parameters to represent cell-killing mechanisms. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology, managing the potential for normal tissue complications following radiotherapy. Understanding the fundamental principles of radiobiology is crucial for predicting and mitigating these risks. The challenge lies in translating theoretical radiobiological concepts into practical clinical decision-making, especially when patient factors and treatment complexities intersect. A physician must balance the therapeutic benefit of radiation with the inherent risk of damage to healthy tissues, adhering to established guidelines and ethical considerations for patient care. Correct approach analysis. The correct approach emphasizes the application of the linear quadratic LQ model to predict the probability of normal tissue complications. This model, a cornerstone of radiobiology, relates radiation dose, fractionation, and tissue sensitivity to the likelihood of adverse effects. By understanding the alpha and beta components of the LQ model, which represent cell-killing mechanisms, a radiation oncologist can estimate the biological effect of different fractionation schedules. This allows for informed adjustments to treatment plans to minimize late effects while maintaining tumor control, aligning with the principles of ALARA, as low as reasonably achievable, and patient safety, which are implicit in the ethical practice of medicine and regulatory expectations for quality patient care in India. Incorrect approaches analysis. Focusing solely on the physical dose delivered without considering the biological effect is a significant regulatory and ethical failure. Radiation therapy is not merely about delivering a specific dose, it's about the biological consequences of that dose. Ignoring radiobiological principles can lead to under- or overtreatment of normal tissues, increasing the risk of severe complications or compromising tumor control, respectively. This deviates from the standard of care and the expectation of evidence-based practice mandated by professional bodies overseeing medical education and practice in India. Another incorrect approach would be to disregard patient-specific factors that influence radiobiological response, such as age, comorbidities, or genetic predispositions. While the LQ model provides a framework, individual radiosensitivity can vary. Failing to account for these variations means applying a generalized model without personalized risk assessment, which is ethically problematic as it does not uphold the principle of individualized patient care. This can lead to unexpected toxicities or suboptimal outcomes, falling short of the expected standard of care. Professional reasoning. Professionals should approach such situations by first identifying the core radiobiological question at hand in this case, the prediction of normal tissue complications. They should then recall and apply relevant radiobiological models, such as the linear quadratic model, to understand the relationship between dose, fractionation, and biological effect. This involves considering the specific tissue type and its known radiobiological parameters, alpha/beta values. Subsequently, they must integrate patient-specific factors that might modify this response. Finally, they should use this comprehensive understanding to inform treatment planning decisions, aiming to optimize the therapeutic ratio and adhere to ethical obligations of beneficence and non-maleficence, as expected within the Indian regulatory framework for medical professionals. Question 17. The performance metrics show a slight but consistent increase in treatment delivery times for a specific patient cohort undergoing palliative radiotherapy, alongside a marginal but statistically significant rise in background radiation levels within the treatment planning area. Which of the following approaches best addresses this situation in accordance with Indian radiation protection principles and regulatory guidelines? Option A. Implement additional personal dosimeters for all staff involved in patient treatment and schedule mandatory refresher training on radiation safety protocols, without investigating the root cause of the increased background radiation. Option B. Initiate a review of patient positioning techniques and immobilization devices to identify potential inefficiencies contributing to longer treatment times, assuming the background radiation increase is within acceptable, albeit higher limits. Option C. Conduct a comprehensive review of radiation shielding integrity in the treatment planning area and adjacent corridors. Cross-reference patient treatment logs with radiation safety officer reports for any unusual incidents, and reevaluate the calibration and maintenance schedule for all radiation-generating equipment. Option D. Focus on optimizing treatment planning software parameters to expedite dose calculation and verification, considering the increased background radiation as an environmental factor unrelated to the treatment delivery process itself. The correct answer is C. Conduct a comprehensive review of radiation shielding integrity in the treatment planning area and adjacent corridors. Cross-reference patient treatment logs with radiation safety officer reports for any unusual incidents, and reevaluate the calibration and maintenance schedule for all radiation-generating equipment. Explanation. This scenario presents a professional challenge due to the inherent conflict between optimizing patient treatment outcomes and ensuring the safety of healthcare professionals and the public from radiation exposure. The performance metrics, while indicating treatment efficacy, also highlight potential deviations in radiation protection practices. Careful judgment is required to balance these competing priorities, adhering strictly to the established regulatory framework for radiation oncology in India. The correct approach prioritizes a comprehensive review of all radiation protection protocols, including shielding, dose monitoring, and waste management, in conjunction with the observed performance metrics. This aligns with the fundamental principles of radiation protection as mandated by Indian regulations, which emphasize ALARA as low as reasonably achievable for all individuals. Specifically, the Atomic Energy Regulatory Board (AERB) guidelines and the Radiation Protection Rules, 1976, necessitate a proactive and systematic approach to radiation safety. By investigating potential breaches in shielding or inadequate personal protective equipment that might correlate with performance variations, this approach ensures compliance and upholds the ethical responsibility to protect all stakeholders. An incorrect approach would be to solely focus on improving treatment delivery techniques without a parallel review of radiation safety. This fails to acknowledge that suboptimal radiation protection measures, such as inadequate shielding or improper handling of radioactive sources, could indirectly impact treatment delivery or lead to unnecessary exposure. Such an approach would violate the spirit and letter of Indian radiation protection laws, which demand a holistic safety culture. Another incorrect approach would be to dismiss the performance metrics as unrelated to radiation protection, attributing any observed variations solely to patient factors or technical nuances of treatment planning. This demonstrates a failure to critically analyze all contributing factors to patient outcomes and operational efficiency, potentially overlooking significant safety lapses that could have long-term consequences. It neglects the interconnectedness of treatment quality and radiation safety, a core tenet of responsible radiation oncology practice. Finally, an approach that involves implementing new technologies without a concurrent reassessment of existing radiation protection measures is also flawed. While technological advancement is crucial, it must be integrated within a robust safety framework. Failure to do so risks introducing new exposure pathways or exacerbating existing ones, contravening the precautionary principle embedded in radiation safety regulations. The professional decision-making process in such situations should involve a systematic risk assessment. This includes identifying potential hazards, evaluating the likelihood and severity of harm, and implementing control measures. When performance metrics suggest a deviation, the first step is to investigate the underlying causes, considering both treatment-related and radiation protection-related factors. This requires collaboration between radiation oncologists, medical physicists, radiation safety officers, and nursing staff. Regular audits, adherence to AERB guidelines, and continuous professional development in radiation safety are essential components of maintaining a safe and effective radiation oncology practice in India. Question 18. Market research demonstrates a growing interest among radiation oncologists in understanding the nuanced cellular responses to radiation therapy to refine treatment strategies. Considering the mechanisms of radiation damage to cells, which of the following approaches best represents a robust risk assessment for optimizing therapeutic outcomes and minimizing normal tissue toxicity in a clinical setting? Option A. Focusing on the cumulative dose delivered to the tumor without detailed consideration of cellular repair mechanisms or cell cycle kinetics. Option B. Prioritizing treatment planning based on the physical dose distribution alone, assuming all tissues respond uniformly to radiation. Option C. Systematically evaluating the types of radiation-induced DNA damage, the cell's repair capacity, cell cycle phase, and the differential radiosensitivity of tumor and normal tissues to predict treatment response and toxicity. Option D. Relying solely on historical treatment outcomes for similar tumor types, without re-evaluating the underlying radiobiological principles in light of current research. The correct answer is B. Prioritizing treatment planning based on the physical dose distribution alone, assuming all tissues respond uniformly to radiation. Explanation. Scenario analysis. This scenario presents a professional challenge in a clinical setting where a radiation oncologist must interpret complex cellular mechanisms of radiation damage in the context of patient treatment planning. The challenge lies in translating fundamental radiobiological principles into practical, risk-assessed decisions that optimize therapeutic outcomes while minimizing toxicity. This requires a deep understanding of how different radiation doses and fractionation schedules interact with cellular repair pathways, cell cycle kinetics, and genetic material, all within the framework of established Indian regulatory guidelines for radiation oncology practice. The pressure to make informed decisions based on this understanding, especially when considering novel treatment approaches or managing treatment complications, necessitates a robust risk assessment methodology. Correct approach analysis. The correct approach involves a systematic risk assessment that integrates knowledge of radiation-induced DNA damage, e.g., single-strand breaks, double-strand breaks, the cell's ability to repair this damage, e.g., via homologous recombination, non-homologous end joining, and the impact of cell cycle phase and radiosensitivity on overall tumor control and normal tissue complication probability. This approach aligns with the National Board of Examination's emphasis on applying scientific principles to clinical practice, specifically understanding the dose-response relationship and the concept of biologically effective dose, BED, allows for the rational selection of treatment parameters that maximize tumor cell kill while staying within acceptable normal tissue tolerance limits, as implicitly guided by Indian Medical Council regulations and ethical standards for patient care. This method prioritizes patient safety and treatment efficacy by making evidence-based decisions grounded in radiobiological understanding. Incorrect approaches analysis. One incorrect approach would be to solely focus on the physical dose delivered without considering the underlying radiobiological consequences at the cellular level. This fails to account for the differential sensitivity of tumor cells versus normal tissues, the impact of fractionation on repair, and the potential for sublethal damage accumulation. Such an approach is professionally unacceptable, as it neglects critical factors that determine treatment outcome and toxicity, potentially leading to suboptimal treatment or increased complications, which would be a breach of the duty of care expected under Indian medical practice. Another incorrect approach would be to rely on anecdotal evidence or outdated protocols without critically evaluating the cellular mechanisms of radiation damage. This ignores advancements in radiobiology and the evolving understanding of how radiation interacts with biological systems. Professionally, this demonstrates a lack of commitment to continuous learning and evidence-based practice, which is a cornerstone of responsible medical practice in India. It could lead to the use of ineffective or unnecessarily toxic treatment regimens. A third incorrect approach would be to overemphasize the role of specific molecular pathways in isolation without considering their interplay and the overall cellular response to radiation. While understanding specific pathways is important, a holistic view of radiation damage and repair is crucial for accurate risk assessment. Focusing too narrowly can lead to misinterpretations of experimental data or an incomplete understanding of the clinical implications, potentially resulting in flawed treatment decisions that do not adequately protect patient interests. Professional reasoning. Professionals in radiation oncology should adopt a decision-making process that begins with a thorough understanding of the patient's specific clinical situation, including tumor type, stage, and patient factors. This is followed by a comprehensive review of relevant radiobiological principles, focusing on how radiation induces damage and how cells respond. The next step involves applying these principles to the specific treatment scenario, considering dose, fractionation, and delivery techniques. A critical risk assessment should then be performed, evaluating the potential for tumor control versus the likelihood of normal tissue complications. This assessment should be informed by established guidelines and evidence-based literature, always prioritizing patient safety and well-being. Regular reevaluation of the treatment plan and patient response is also essential, allowing for adjustments based on observed outcomes and evolving understanding of the underlying radiobiology. Question 19. Implementation of a new intensity-modulated radiation therapy IMiD treatment plan for a locally advanced head and neck cancer patient requires careful evaluation. Which of the following approaches best reflects a comprehensive and clinically responsible assessment of the plan's adequacy and safety, adhering to the principles of best practice in radiation oncology as expected for DNB trainees? Option A. Forming a thorough review of the dose volume histograms, DVH, for all critical OARs, comparing them against established institutional or national dose constraints, and verifying that the PTV coverage meets the prescribed dose and homogeneity requirements. Option B. Relying solely on the treatment planning system's automated plan quality metrics and accepting the plan if it falls within the system's default acceptable ranges. Option C. Prioritizing the reduction of OAR doses to the absolute minimum achievable, even if it compromises target coverage or introduces significant treatment delivery complexities. Option D. Confirming that the prescription dose is delivered to the planning target volume, PTV, and that the overall treatment time is within the planned schedule, without detailed review of organ at risk or dose constraints. The correct answer is D. Confirming that the prescription dose is delivered to the planning target volume, PTV, and that the overall treatment time is within the planned schedule, without detailed review of organ at risk or dose constraints. Explanation. The scenario presents a common challenge in radiation oncology treatment planning, balancing the need for accurate target coverage with the imperative to minimize dose to organs at risk or. This requires a deep understanding of the treatment planning system's capabilities, the specific radiobiological parameters of the tumor and OARs, and adherence to established clinical protocols and guidelines. The professional challenge lies in making informed decisions that optimize patient outcomes while adhering to regulatory standards for patient safety and quality assurance, as mandated by the National Board of Examinations in India for Diplomate of National Board (DNB) in radiation oncology. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based, and collaborative method for treatment plan evaluation. This involves a thorough review of the dose volume histograms, DVH, against established constraints, a critical assessment of the plan's ability to achieve the prescribed dose to the target volume, and a clear understanding of the potential toxicities associated with the proposed dose distribution. This aligns with the DNB curriculum's emphasis on developing competent radiation oncologists who can critically evaluate treatment plans and make decisions that are both clinically effective and ethically sound, ensuring patient safety and quality of care within the Indian regulatory framework. An incorrect approach that solely focuses on achieving the prescription dose without adequate consideration of OAR constraints represents a significant regulatory and ethical failure, violates the principle of beneficence and non-maleficence by potentially exposing the patient to unacceptable levels of toxicity, which is contrary to the ethical guidelines governing medical practice in India and the quality standards expected of DNB trainees. Similarly, an approach that relies on subjective assessment without objective DVH analysis or consultation with the multidisciplinary team, e.g., radiation physicist, radiation therapist, demonstrates a lack of due diligence and a failure to adhere to established quality assurance protocols. This can lead to suboptimal treatment delivery and increased risk of adverse events, falling short of the rigorous standards set by the National Board of Examinations. Professional decision-making in such situations requires a structured approach. First, understanding the clinical context and treatment goals. Second, critically evaluating the treatment plan using objective metrics like DVHs and comparing them against established institutional or national guidelines. Third, engaging in multidisciplinary team discussions to address any discrepancies or concerns. And finally, documenting the rationale for the chosen plan, ensuring transparency and accountability. This systematic process ensures that all relevant factors are considered, leading to the safest and most effective treatment for the patient, in line with the DNB program's objectives. Question 20. Governance review demonstrates that a radiation oncology department is evaluating its protocols for managing patients with head and neck squamous cell carcinomas. A key discussion point revolves around the radiobiological basis for dose escalation strategies. Clinicians are debating whether the dose-response relationship for tumor control is best represented by a linear model or a nonlinear sigmoidal model, and how this impacts the acceptable dose to critical structures like the brainstem. Which of the following interpretations of dose-response curves is most critical for optimizing the therapeutic ratio in this context? Option A. Recognizing that the dose response for tumor control is typically nonlinear and sigmoidal, with a steep rise in efficacy after a certain threshold, while normal tissue complication probability, NTCP, for late effects also exhibits a nonlinear sigmoidal relationship, necessitating careful balancing to avoid exceeding tolerance limits. Option B. Prioritizing a linear dose response for normal tissue tolerance, suggesting that even small dose increments above a baseline will lead to significant complications, and therefore advocating for dose reduction to all critical organs regardless of tumor response. Option C. Assuming a linear dose response for both tumor control and normal tissue complications, implying that any dose increase will proportionally increase both positive and negative effects, thus simplifying treatment planning by directly correlating dose with outcome. Option D. Focusing solely on a linear dose response for tumor control, believing that maximizing dose is always beneficial for tumor eradication, and disregarding the potential for nonlinear increases in normal tissue damage at higher dose levels. The correct answer is A. Recognizing that the dose response for tumor control is typically nonlinear and sigmoidal, with a steep rise in efficacy after a certain threshold, while normal tissue complication probability, NTCP, for late effects also exhibits a nonlinear sigmoidal relationship, necessitating careful balancing to avoid exceeding tolerance limits. Explanation: this scenario presents a professional challenge in radiation oncology by requiring the application of fundamental radiobiological principles to clinical decision-making, specifically concerning the interpretation of dose-response relationships. The challenge lies in translating theoretical understanding of linear and nonlinear dose-response curves into practical treatment planning and patient management, ensuring adherence to established clinical guidelines and ethical considerations within the Indian regulatory framework for radiation oncology. Careful judgment is required to select the most appropriate approach based on the specific radiobiological characteristics of the tumor and normal tissues involved. The correct approach represents best professional practice because it aligns with the principles of evidence-based medicine and the ethical imperative to optimize treatment efficacy while minimizing toxicity. Understanding that different biological endpoints, e.g., tumor control vs. normal tissue complication probability, can exhibit distinct dose-response relationships is crucial. A linear dose response suggests a direct proportionality between dose and effect, often associated with deterministic effects at higher doses or stochastic effects. A nonlinear dose response, particularly a sigmoidal curve, implies a threshold dose below which the effect is negligible, and then a rapid increase in effect with further dose escalation, often seen with late normal tissue effects or some tumor responses. Applying this knowledge allows for precise dose prescription and fractionation schemes that maximize the therapeutic ratio, directly impacting patient outcomes and safety, which are paramount under the National Board of Examination's purview. An incorrect approach that assumes a universal linear dose response for all biological effects in radiation oncology would be a significant regulatory and ethical failure. Disregards the established radiobiological evidence that demonstrates nonlinear relationships for many critical endpoints, particularly late normal tissue effects. This could lead to underdosing if a threshold effect is not considered, or overdosing if the steep portion of a nonlinear curve is not respected, potentially increasing the risk of severe complications without a commensurate increase in tumor control. Ethically, this represents a failure to provide the standard of care and a breach of the duty of beneficence and non-maleficence. Similarly, an approach that solely focuses on tumor control without adequately considering the nonlinear dose response of normal tissues would also be a failure, as it prioritizes one aspect of treatment at the expense of patient safety and quality of life, violating the principle of non-maleficence. Professional decision-making in such situations should involve a systematic process. First, identifying the specific biological endpoints relevant to the treatment scenario: tumor control, acute toxicity, late toxicity. Second, recalling or researching the established dose-response characteristics for these endpoints, distinguishing between linear and nonlinear models. Third, integrating this radiobiological understanding with clinical factors such as tumor type, stage, patient comorbidities, and treatment intent. Finally, applying this comprehensive understanding to select appropriate dose, fractionation, and treatment techniques that optimize the therapeutic ratio, always in accordance with the latest clinical guidelines and regulatory requirements applicable in India.